Good afternoon, everyone. Welcome to the Health and Human Services Finance Division. I know that there are some materials that are getting passed out, and there is a fiscal note coming that will be handed out when it's being copied, I understand. But I think that we have a lot on our plates today, so I think we should try to get started. And we are going to be hearing House File 3100, which is the Alec Smith insulin bill, which has made a lot of committee stops. So many members may have already heard the bill in one place or another. What I would like to do today, we have a number of testifiers who've signed up to testify. We are going to, since this is the fiscal committee, we're going to try to focus on the fiscal aspect of the bill, but we do want to have some introduction of the bill, and so for members who haven't heard it or members of the audience who haven't heard it to understand the bill. And then, let's see, I will move that House File 3100 be recommended to be referred to the Committee on Ways and Means. And I see that there are a number of amendments in the packet. And Representative Howard, do you want to get those on the bill first, or do you want to explain them as we go along? And we do have a quorum, by the way. I should announce that. There is a quorum present. Do you want to do that and then start to discuss the bill, or what would be your preference?
Madam Chair, I'm comfortable either way. Potentially, there are two amendments, that the A6-2 and then the A12, which is an amendment to the amendment that gets the bill in the shape to discuss it, and maybe we could do the other two amendments separately. I'm open with what the committee would
Well,
prefer.
that's, I'm not really familiar with the amendments, and you are, so that I would take your lead on that. So that sounds just fine. So I would move the first of all, the A6-2 to get that before us, if members have that. And then you want to move the amendment to the amendment, the A12.
Yes, Madam Chair.
Okay, so first I will move the A12 amendment to the amendment to get the A6-2 amendment in the form in which you would like to discuss it. So would it make sense to explain that, or should we just put on the amendment to the amendment and then discuss?
That probably makes the most sense.
Okay. So members, we have the A6-2 before us, and then I'm moving the A12 amendment to that amendment to get the amendment in the order in which the author would like to discuss it. So all those in favor of the A12 amendment to the amendment, please say aye.
Aye.
Opposed, no. Motion prevails. Okay. So then, Representative Howard, to the A6-2 as amended, if you want to just tell us what that's doing. And remember, we still, in theory, don't know what the underlying bill is doing. So.
Thank you, Madam Chair. I'll just touch, largely this amendment includes feedback from the administration, technical language, a few changes in dates. I did want to call out a few pieces. The amendment on line 1-2 is based on feedback from Representative Quam and Government Operations Committee related to the contracting with a third-party administrator. The other piece that I'll highlight that we can touch base on later related to the fee that is relevant, we've included language, what I would really call a settle-up, in that if the fee on insulin manufacturers collects too much money, we would refund those monies to the three insulin manufacturers. Those are the substantive pieces of the amendment.
Okay. Are there questions then about the A6-2 as amended? All right. Seeing none, all those in favor of the A6-2 as amended, please say aye.
Aye.
Opposed, no. Motion prevails. So now, Representative Howard, we have the bill sort of in the form in which you'd like to discuss it. Maybe if do you want to go ahead and present the bill at this point?
Madam Chair, maybe we should just do these other two amendments. I hate to.
Okay.
Yeah.
I'm certainly happy to do that. So Should we just take up the A7-1, or is there an order? Okay, let's take up then, so the chair moves the A7-1 amendment.
Madam Chair, this amendment was adopted to our clone bill when we discussed this in civil law. It was brought forward by Representative Scott related to data privacy and protecting data privacy for patients.
Oh, okay. And so Representative Howard, I sit on that committee. I remembered the discussion, and so we didn't adopt anything in that committee. This was held over here because of 24-hour rule or something? Oh, we did adopt it. I'm sorry. Okay, okay, Mr. McQuillan is reminding me. So this was, as members know, because this bill is moving quickly through the body, there are some clones out there that are being heard in different committees, and this brings the bill, the current version, into the order in which it came out of judiciary. So Representative Scott did some work on the privacy concerns, the data concerns, and this just makes this bill consistent with the clone.
Yes, Madam Chair.
Okay, so are there any questions about that from members? All right, seeing none, all those in favor of the A7-1 amendment, please say aye. Aye. Opposed, no. The motion prevails. And, you know, as we said in that committee, we really appreciate her work on that. She's kind of an acknowledged expert in this body on those data privacy issues. So the chair moves the A11 amendment. Representative Howard.
Madam Chair, this is just related to effective dates where we needed to move 2020 to 2021.
Okay, technical amendment. Any questions from members? Seeing none, all those in favor of the A11, please say aye. Aye. Opposed, no. Motion prevails. And the A10, the chair moves the A10 amendment. Representative Howard.
Madam Chair, this is related to, we want to be clear that the insulin we're talking about that would be, this bill would be applicable to is the insulin that patients receive at the pharmacy. There is insulin that may be delivered at a hospital intravenously, and we want to clarify that that type of insulin isn't going to be captured as part of this fee on insulin manufacturers.
Okay, thank you. Are there questions to the amendment? Seeing none, all those in favor of the A10, please say aye. Aye. Opposed, no. Motion prevails. Okay, we got through all the sort of housekeeping stuff here, Representative Howard, and please go ahead and present your bill, or if your testifier wants to do that.
Thank you, Madam Chair. I'll be brief because I know this committee heard a version of this bill last year. But also, as you know, although we've been working on this a year, we have not reached a conclusion on something that is where lives are at stake. In the last 10 years, the price of insulin has tripled. A vial of insulin that once cost $30 now costs over $300. We've lost Minnesotans, and we know that 1 in 4 are rationing their insulin, which is so dangerous. What this bill is a product of the work that's happened since the session ended without a resolution. And I do want to call out the work of some of the members of this committee, Representative Mann, Representative Hamilton, Representative Liebling, that participated in various working groups and negotiations over this bill for many months. And what we have here is a bill that represents good ideas from both Democrats and Republicans, really under the umbrella of 4 objectives: addressing the emergency issue facing Minnesotans who can't afford their insulin, addressing the long-term issue of securing long-term care, affordable care for patients, to set up a program up quickly, and to ensure that pharmaceutical companies contribute to the solution. The path of this bill for a patient is that if they're in need of affording their insulin and they can't afford it, they can go in their pharmacy and get an emergency fill of insulin that day in the pharmacy. We also connect patients through a navigator in MNsure to assess their long-term options. If they're available for a public program, make sure we get them signed up so that we can prevent future emergencies and get folks onto dependable coverage. And we also codify cost-sharing language to cap copays for Minnesotans whose insulin is already capped. The eligibility is essentially the Minnesotans most at risk of rationing. And really what we're talking about here are folks that are earning enough money where they don't qualify for public assistance, but still might not be able to afford the crushing cost of their insulin. So that includes Minnesotans that are uninsured, underinsured, that have high deductible health plans with high out-of-pocket costs, and Minnesotans on Medicare with large out-of-pocket costs. This bill is funded through a combination of public dollars and a fee in insulin manufacturers. There are about $900,000 in initial public funds through the Department of Administration and MNsure to get this program up and running. The fee on just the 3 large insulin manufacturers that control the global supply of insulin would be assessed a fee that largely covers the cost of the insulin, as well as ongoing operational costs going forward. I just want to call out that had we passed Alec's bill in 2019, it would be the law of the land. And since our session ended, we know of at least 2 Minnesotans that have died rationing their insulin. This is deadly serious, and I'm grateful that we are moving forward quickly to get this across the finish line, because we simply cannot lose another Minnesotan on our watch. Thank you, Madam Chair.
All right, well, thank you very much, Representative Howard. And we have Nicole Smith-Holt. Welcome to the committee, and please introduce yourself and go ahead.
Well, good afternoon, Madam Chair, members of the committee. My name is Nicole Smith-Holt, and my son Alec Smith died on June 27th of 2017 from DKA, or diabetic ketoacidosis, at the age of 26. He is one of 16 other young adults who have recently passed away from rationing their insulin. 2 of those are from Minnesota. The list keeps growing, and this keeps happening because insulin is unaffordable. It's not an easy subject to talk about because the system is complex, but it boils down to the fact that pharmaceutical industry is only concerned with profits. They could really care less how many of our loved ones are laid to rest, because there are more than 40,000 new people diagnosed yearly. 40,000 new people to drive into bankruptcy or into an early grave. 1 in 4 type 1s have reported that they are currently or have recently rationed their insulin because they cannot afford to regularly purchase it. On any given day, you will find someone in DKA in our emergency rooms or in an ICU bed, which typically results in a $10,000 a day bill. Why would we not want to do everything in our power to prevent this? Why would we not want to be the first state to create a safety net? Why are we okay with the status quo? Well, I'm not okay with that. And I am not okay with adding names to the long list of those who have died simply because of cost. Type 1 diabetes is manageable with access to insulin, but without it, 100% of them will die. I recently read a new article that talks about how young adults in Canada with type 1 are 3 times more likely to attempt suicide. There hasn't been a study on young adults in the U.S., but I'm willing to bet my last dollar that the rate is much higher since we have the added burden of financial stress. Our young adults are not prepared for the financial burden that is placed upon them. And I am here today to encourage you to pass the Alec Smith Insulin Affordability Act. The first version of this bill was introduced on March 28th of 2018 by Representative Aaron Murphy. Since then, the bill has been made stronger with the help of advocates. Today, you will hear compelling testimony from people who are walking the walk, people who are living with the day-to-day struggles to basically stay alive. And I urge you to listen to these stories, to try to put yourselves in their shoes and to do the right thing. Because unfortunately, right this very minute, there is someone at home rationing their insulin. And I pray that they are still alive tomorrow, that they are still alive when this bill passes and they have the benefit of using it. Thank you.
Thank you very much, Ms. Smith-Holt. Appreciate your being here and all your advocacy around this issue. Next, and members, I'm just going to ask us to hold questions. We have a list of testifiers, and then we are going to have the fiscal note and And then hopefully we'll be able to have time for questions and discussion. Next, I'd like to call up Mary Turner, President of the Minnesota Nurses Association. And then after that, I'm going to go to Kim Munson. And then we'll go back to the others that are on the list. Welcome to the committee.
I'm finishing my mint, sorry. Okay. Good afternoon, Madam Chair and committee. My name is Mary Turner. I am presently the president of Minnesota Nurses Association. I have been a registered nurse since 1995, and I'm actually a practicing intensive care nurse at North Memorial in Robbinsdale for the past 10 years. In fact, I just got off the night shift, a stretch of nights. I am here in a little bit different vein to kind of give you what the front lines has been like with those suffering from diabetes or more importantly, the lack of insulin when they need it. I have two stories that kind of tell the whole story. So a few years back, I was at that point a trauma intensive care nurse. And one night I had two patients that had fallen because they weren't taking their insulin. They had a diabetic crisis. They fell and they were now in the intensive care. They were both intubated, meaning they were on breathing machines. One of them at the beginning of my shift had gotten extubated, so he was not intubated anymore. Let's call him Harold. It was 3 in the morning and I went to Harold's bedside and I said, Harold, why weren't you taking your insulin, Harold? What went wrong that you weren't taking your insulin? And he whispered in this very defeated voice, I'm sorry, Mary, I ran out of money. I'm sorry, Mary, I ran out of money. The second gentleman, who was still intubated, who had fallen, he had insurance. He could afford his insulin. However, his son, who was also diabetic, did not have insurance, and so he was giving half of his insulin to his son so that his son could live. At the time, the cost of an intensive care bed at North Memorial, and North Memorial has been touted by insurance companies as being a very reasonable hospital as far as pay-wise. One night in the ICU just for the bed was $6,000 to $8,000 a night. That's just for the bed. That's not counting emergency costs or the ambulance or any of the medicine. My second story took place not too long ago when I was about a year and a half ago, when now I'm a medical intensive care nurse. And we had one night from 2300 to 3 o'clock in the morning, we had 5 patients come in 5 hours in diabetic crisis on our 13-bed unit who were all put on insulin drips. 5 patients in 5 hours. I'm here to tell you that 1/3 of the intensive care patients nowadays are people coming in some kind of diabetic crisis. I just looked up yesterday, went to our North Memorial site to see how much an intensive care bed now costs, just the bed, and that is anywhere from $9,000 to $11,000 a night. This doesn't make sense. This is not the way to manage this disease. If we're truly care about both the insurance and the government, and if we truly care about keeping hospital costs down or healthcare costs down, then it makes more sense, even at the price that a regular insulin, what did you say, 300? It makes more sense for people to get their insulin than to be coming in and generating these costs. And that's kind of my message today. Thank you.
Thank you very much for your testimony, and if you could stay around in case there are questions later when we get there. Kim Munson. And no relation to Representative Munson, right?
Thank you. No, I've been asked that many times over the course of my advocacy, and we are not related in any way.
All right, welcome.
Thank you. Good afternoon, Madam Chair and members of the committee. My name is Kim Munson, and I am here as a mother to a 8-year-old daughter back here who has type 1 diabetes and was diagnosed at the age of 8 years old. And today I would like to focus my testimony on why I believe insulin manufacturing companies should participate in the contributions to the Alex Smith Insulin Affordability Act, and why I believe list price matters. And to do that, I would like to share a personal story that happened to me last summer in the state of Minnesota. And I want to preface this by saying that I am not Mom of the Year. Last summer, I took my 2 daughters up to Moorhead, which is where I'm originally from. We spent about 5 days there on a little mini vacation. And the day before we were about to leave, I had to change my daughter's infusion set because her insulin pump was out of insulin. Not a huge deal. I went to change her infusion set, and I discovered that I was about to use the last of her insulin. Again, not a huge deal because I was about to put 100 units of insulin in her insulin pump. So everything was set to go. I went ahead and took care of everything. She hates getting her pump changed, but she managed because she's a rock star. But about 2 to 3 hours later, I started to notice that her blood sugar was increasing, and for no reason. She wasn't consuming a terrible amount of carbohydrates, and I was giving her insulin, which should naturally be reducing her blood sugars to normal ranges. But after a few more hours, her blood sugar kept on rising. And I came to the conclusion after kind of going to the back of my memory here, because I was trained at Children's of St. Paul. I was trained really well as a diabetes mom, that something was wrong with this insulin because her blood sugars were going into the 300s, 350s, and this was after a number of hours. And this is when the emergency in my mind started to, the emergency lights went off in my mind. Something needed to happen. I needed to change her insulin pump. And unfortunately, I was in Moorhead. I wasn't in Lakeville, which is where I met. I didn't have any insulin, right? And I wasn't actually that worried right away because thankfully, due to the special session in Minnesota, I knew that there was a special provision that was written into law that would allow me as a person in the state to go to a pharmacy that should theoretically allow me to get an emergency prescription without a valid prescription because, totally off the subject because, you know, I have this pharmacy benefit manager that forces me to go to mail order to get the most insulin for the least amount of money. I don't get the benefit of going to a walk-in pharmacy to get my insulin. So I just didn't have a active prescription at a pharmacy. But anyway, I knew that there is a local pharmacy in Moorhead that had an expired prescription. So I called that pharmacy and said, look, my daughter, I'm concerned she's going to go into diabetic ketoacidosis. She hasn't had insulin, a steady stream of insulin, and I need you to fill this prescription for me. Unfortunately, they hadn't heard of this new law in Minnesota, and they wouldn't honor the prescription. But thankfully, by the end of this 20-minute conversation with crazy mom freaking out at them, they did contact the pharmacy benefit manager and transfer the active prescription over, and they were going to work with me here. By the way, time out, Dr. Weiberg and Senator Melissa Wicklund did fix that, sidebar, so hopefully that won't happen to another person with diabetes again. Anyway, so we got an active prescription on file. I'm thinking, I'm going to get insulin to my daughter with diabetes. Her blood sugars are in the 400s now. I'm freaking out thinking, do I need to go to an out-of-network hospital in Fargo, North Dakota to get her insulin very quickly? And I thought we were going to be okay, right? Well, guess what? Then I found out this particular community pharmacy didn't have the exact type of insulin, because they're really specific with these pharmacy benefit managers. So it has to be the very specific vial, right? And the type of prescription I had didn't match. So then they had to transfer it over to another pharmacy. And I'm getting really upset here because this is all taking more time. So I go over to another prescription or another pharmacy across town. And then come to find out, oh, there's not insurance on file. And I'm livid at this point, and I'm thinking, do I need to go to a hospital or what should I do? And of course, I don't have my insurance card, and I can't get in touch with my husband. So at this point, I just say, fine. community pharmacist person, tell me how much I owe. I just want to buy this prescription of insulin out of pocket. Here's my credit card. How much do I owe you? $1,350, please. Okay. Now, I'm not, yes, could I maybe whip out my credit card and pay $1,350? Yes, but you know what? I'm not going to be able to pay that off at the end of the month. We have other utilities, mortgage and everything else. So you know what I did? I put my credit card back in my pocket and I sat back at the end and I just prayed that my daughter wouldn't go into diabetic ketoacidosis. And that is the moral of the story, why list prices matter, and why I believe that the manufacturing companies at the end of the day are partially responsible and should be participating in the funding for the Alex Smith Emergency Insulin Act. Now, contrary to what some people might believe, I'm not a Nazi socialist. I'm not a communist. I happen to have many people in my family who are small business owners, 150 years of farmers in my family. So yes, I do believe that reasonable profits for pharmaceutical companies, pharmacy benefit managers, whatever, are appropriate. But this is price gouging. If this isn't price gouging, I don't know what is. So perhaps I'd be a little bit more sympathetic to the manufacturing companies if they did not dominate 90% of the world insulin market. I would maybe be a little bit more sympathetic to the concerns of the manufacturing companies if they didn't dissuade the FDA from creating this alternative pathway to biosimilars that we continue to hear about. Just last week, I heard that 2 out of the 3 insulin manufacturing companies are not going to let that happen. I would be a little bit more sympathetic if they didn't pay other companies to delay the introduction of other, introduce other companies from entering the market. I would also be a little bit more sympathetic if some of these programs that many people, even in this committee, keep saying they're working, they're so successful. Well, I was listening to a hearing last week, only 500 Minnesotans right now are even participating in these programs that so many people say are so amazing. And those programs, by the way, say that at any time you can they will rescind them, they will revoke them, or remove them. So listen to that. At any time. Those programs can be rescinded, revoked, or removed. I don't want my child at any time to have that. She deserves better than that. She's 8 years old. She didn't deserve to get diabetes. And lastly, let's talk about Lantus, for instance. Lantus is my daughter's long-acting insulin. There are 72 patents right now against Lantus alone. Lantus has been on the market for over 20 years. Okay? So I get it. I know that there are other players in the supply market chain, and absolutely they are participating in the markup of pharmaceuticals, and they should absolutely be paying. And I'm so glad to see so many people in this room who are co-sponsoring bills or sponsoring bills to address that. And I thank you for that. But I can tell you one thing, pharmaceutical companies deserve to pay as well. So I'm asking every one of you here to side on the side with Minnesotans, not manufacturing companies. Thank you.
Thank you very much, Ms. Munson. I'm going to next call Catherine Commit, and then Sharon Lamberton, and then Sarah Durr. And then we will go through the fiscal note, which has been distributed. So welcome to the committee.
Thank you, Madam Chair and members of the committee. My name is Catherine Commit, and I'm from the Minnesota Council of Health Plans, the association that represents Minnesota's 7 nonprofit health plans. Thank you for the opportunity to testify on this important issue. We appreciate all of the work that Representative Howard and so many others have put into finding solutions to making sure Minnesotans have access to life-saving insulin. We share that same goal, and that is why the Council supports the majority of this bill. However, we do have concerns with the language in Section 3 that would place a permanent cap on insulin copays at $30 per month. The ever-increasing price of insulin has created an affordability crisis that threatens the health and well-being of patients. The increasing price of insulin has even led some patients to put their own health at risk. That is why Minnesota's nonprofit health plans independently and voluntarily stepped up to offer products in the fully insured market with low or no copays for a variety of insulin products. A number of factors affected how each health plan arrived at this decision. The main reason was to promote adherence, that is, to help patients successfully manage and control their diabetes, prevent complications, and improve their quality of life. The health plans made this decision because it's the right thing to do. Making sure people with diabetes have access to affordable insulin means they are much more likely to take their insulin regularly and stay healthy. It is completely understandable why advocates support mandating copay caps. When living with a chronic disease that requires daily use of a medication, patients want predictability when it comes to the price they'll pay throughout the year. Health plans also want price predictability, and they set the premiums based on the best estimate of expected healthcare costs for that coming year. However, drug companies are not held to that standard. They can increase prices at any time of the year, and they do. The health plans work to keep premiums as low as possible, with limited but important tools such as formularies, copays, and cost sharing, all of which are designed to help manage the growing costs and minimize their impact on premiums. Establishing drug formularies and negotiating lower prices with drug companies are what health plans do to drive better value for enrollees. When drug companies have to compete for their drugs to be placed on the formulary, they are more likely to offer price discounts. But if health plans are mandated to cover every type of insulin or cap the copays, health plans will lose negotiating leverage to drive down the price of insulin for enrollees. The bottom line is this. If the legislature mandates all insulin copays are capped, the drug companies will charge more and more for insulin because they can. Mandating copay caps doesn't address the real problem. The price of insulin is too high. Mandating copay caps will ultimately lead to higher health insurance premiums for everyone, making coverage less affordable and resulting in more people becoming uninsured. We urge the legislature to focus on the root cause of this problem, the price of insulin as set by the drug companies. We look forward to working with Representative Howard and others on developing innovative solutions that put downward pressure on the price of insulin. Thank you, Madam Chair and members, for the opportunity to testify.
Thank you, Ms. Kmitt. Sharon Lamberton.
Good afternoon, Madam Chair,
Good afternoon.
members of the committee. My name is Sharon Lamberton. I'm with the Pharmaceutical Research and Manufacturers of America, a trade association based in Washington, D.C. that represents 38 member biopharmaceutical companies, 3 of which make and manufacture insulin. I'm proud that our companies have invested more than $900 billion since 2000 in the search for new and life-saving treatments and cures, just $79.6 billion in 2018. I'm a registered nurse by training, and diabetes is near and dear to my heart. My mom has suffered from type 2 diabetes for the past 30 years. She lives in Arkansas, and I've watched her over the years lose her eyesight. She's had renal conditions, she's had cardiovascular disease, and loss of sensation in her hands and feet. I've also seen some incredible advances in the medicines that she's taken over the past few years. Now we're seeing things that allow better dosing options. We see inhalable insulin, which is a great option for pediatric patients, and more. But more needs to be done. It's very important to understand that today's insulin is not the insulin of 1923, developed from a pig pancreas. It's cost a lot of money and time to develop these advances that are now improving people's lives. And with 170 new medicines in the pipeline, that gives us a lot of hope. But it does us no good if patients can't afford that. Given the complexities of the chronic disease of diabetes and the day-to-day challenges of managing it, it's very important that patients should not worry about affording insulin, which is why today's conversation is so very important. Biopharmaceutical companies that research and develop insulin also offer patient assistance programs. The patient assistance programs offer a range of help to patients, and that information can be found on their website. But in addition to that, pharma has something called the Medication Assistance Tool. mat.org. It's a compilation of over 900 public and private programs that offer free or nearly free medicines to patients that need it. A caregiver like myself or a nurse or a provider can get on the website, they can type in the medicine they need, and they can see if they qualify for those assistance programs. We also offer coupons, which are helpful. But overall, it is clear that our insurance is not working like insurance, and patients are unfairly paying prices. Right now, patient out-of-pocket costs are going up, while supply chain stakeholders are getting more and more. A recent BRG study showed that supply chain stakeholders are now getting over 46% of the cost of medicines. It is not going down to the patient at the point of sale at the pharmacy. Why aren't discounts being shared with patients? For insulin, some of these rebates and negotiations can mean that insulin, the net price of insulin, it can be lowered by 70% or more. Costs of insulin are staying flat after you take out rebates and discounts. This means that almost all insulin list price are returned to the payers. Instead of solving for some of these insurance designs that we see, HF 3100 offers 4 things that we see of concern. One is that it duplicates existing programs that we're talking about, the assistance programs that are available today to help people nationwide, not just in Minnesota. And that would be important to not duplicate those existing efforts. Number 2 is it's ignoring the fact that insurers are the ones that set the price for the drugs that patients are paying. I know that a lot of the insurance companies have adjusted their copays to $0 to $25, which is great, but I think more needs to be done. We also looked at some of the constitutional concerns that HF 3100 poses. The state is requiring manufacturers to provide free product without any compensation. But instead, we'd like to look at some of the solutions that we could work with on this committee to help patients get their affordable medicines now. One of those is talking about sharing the savings, which I just mentioned. We have over 166 billion last year that we've paid out in rebates. Here in the state of Minnesota, it's 527 million. Could we look at even passing a portion of that rebate down to the patient? The second one would be plan designs changing. We already talked about some of the health insurers that have changed their health copays, their copay options, but what if we looked at how health insurers could offer fixed dollar prescription drug copays and no drug deductible or insurance? Co-insurance. And third, the disease management programs that are available. There could be more that's done. An IHS study just recently showed that more than 20 million could be saved per year here in the state of Minnesota, about $409 per beneficiary if we had better programs that showed patients how to use medications as prescribed and help with their adherence that would minimize complications and hospitalizations. These are policies that could have an immediate impact while not duplicating programs that already exist. In closing, we appreciate the commitment of the committee. We especially commend the commitment of Representative Howard. And we would like to work with this committee, but we do not believe this legislation addresses the key issues of why patients have the high out-of-pocket costs. Thank you for your time.
All right, thank you very much. Sarah Durr. Welcome to the committee.
Thank you, Madam Chair and members of the committee. My name is Sarah Durr. I am a pharmacist and the executive director at the Minnesota Pharmacists Association. We represent pharmacists, student pharmacists, and technicians across the state. Thank you for inviting us to testify today. Pharmacists are the most accessible healthcare provider. A number of community pharmacies are open 24 hours a day, 7 days a week, and others are open until 10 p.m. or later. Pharmacies provide incredible access to Minnesotans. Pharmacists provide patients with information, training, and education, and other services when they present and fill an insulin prescription each day in Minnesota. We believe that this legislation provides a solution to build on existing patient assistance infrastructure to the greatest extent possible, and we believe the supply chain infrastructure should continue with manufacturers developing and making insulin products, physicians and other healthcare providers diagnosing and prescribing, and pharmacists and pharmacies counseling patients about using insulin, filling insulin prescriptions, and being a resource for patients and providers. The current insulin delivery and dispensing infrastructure is working, and we appreciate that you acknowledge that in your bill. Thank you to Representative Howard for including reimbursement language for pharmacies to allow pharmacists to provide critical care for these patients. We appreciate the realistic language surrounding costs associated with the program, and this will allow the program to work for patients, providers, and pharmacists. Thank you.
All right, thank you very much, Ms. Durr. So at this point, I know there may be other people in the room who want to testify. I'm going to ask if you do to hold off, because we're going to spend some time now going through the fiscal note, which has been passed out. Mr. Berg is going to just walk us through, at least on a high level. And we realize that, we just got this. I personally haven't had a chance to really read through it. I know members have been kind of multitasking, trying to look at this during testimony too. So we're going to just have the high-level overview, and then we can take questions of testifiers, and we can have discussion about the fiscal note. So, Mr. Burke.
Madam Chair and members, as you indicated, I'll try to go at a very high level. There's a lot of detail in here, and I'll try to draw your attention to, I think, some things that you ought to take out of this and how it connects to the draft in front of you and where there are differences from the draft in front of you. Starting on page 1, the table listing state costs and savings, you see at the top the administration department. And the first thing I'd call your attention to is the Healthcare Access Fund cost of $321 million for, I don't know if there are any members who are also on state government finance. There was quite a bit of discussion. Yeah, 321,000, I'm sorry. There was a great deal of thousand. There was a great deal of discussion about the $400,000 in the bill for the contract for the third-party administrator. Two things that I will mention here. The appropriations that were listed in that section, which are on page 15 of the bill in section 13, have not changed. The Department of Administration anticipates that they will only spend $321,000 on the third-party administrator contract in the first year and costs related to doing the RFP. But the bill still appropriates the $400,000. Any surplus, of course, canceling back to the fund. Moving down the Human Services Department, the author's amendment added a section in that same section 13, which appropriates $26,000 from the Healthcare Access Fund to the Department of Human Services for the first year costs of their admin costs. And it has that specific number in it. In moving down to MNsure, they're anticipating $496,000 in healthcare access fund costs in the first year for the two purposes that are listed. Again, drawing your attention to section 13 on pages 15 and 16 of the draft. That still appropriates $250,000 in each year from the healthcare access fund. And in the case of paragraph C, it is for the navigators, and that's an ongoing appropriation. The others are one-time appropriations out of the fund. The fiscal note makes an assumption that that will be repaid by the insulin assistance account, but the author's amendment took out the repayment option, so there's a cost to the healthcare access fund of $926,000 in the first year, and then ongoing costs of $250,000. And the fiscal note assumes that the first year costs would be repaid, but now the draft is different than that. If you'll note then at the pharmacy board, that's where the revenue from the insulin fee comes in. There is $38.4 million in revenue listed in the first in the first year. The administration department, again going up to the top, is where you see the expenditure for the programs of $36.8 million in fiscal 21. And one other slight, there's a slight mistake in this that'll get, I'm sure there'll be a revised version of the fiscal note. If you look on the state total box in the lower middle of the page, it lists general fund for, with the 38.4 million in insulin fees there, and does as well under the pharmacy board. That should say new fund, not general fund there. Madam Chair, then the rest of the note, I mean, there's a lot of information in the note, as you say, haven't had a lot of time to absorb it. I will draw members' attention maybe to two things that are pretty useful to look at in here on page 9, which is the MNsure section, under the assumptions. If you look at particularly the second and third paragraphs there, it gives you the background information on the assumptions on how many Minnesotans are assumed to be eligible for the programs and the assumed uptake rate. And similarly, when you go to the Department of Administration section on page 15, under their assumptions, you will see a kind of a mirroring of those assumptions again on how many people are going to be eligible for the program and the assumption on uptake. If you go one more page in the Administration Department section on page 16, at the top of the page, you will get specific information on the assumptions that are being made on the cost of insulin and where the main expenditures for the program appear if members are interested in the assumptions on the cost of insulin. Madam Chair, I'm not sure if there's more that I would go into right at this point. I certainly can answer members' questions, and anyone who would like to go over it with myself or department people are
Okay.
available.
Thank you, Mr. Bergen. I do have just one thing. I don't know if you can really answer this, having looked at this briefly, but the cost of the insulin is essentially the cost, the retail cost. So that cost, as we know, even just from the testimony of Ms. Lamberton, the pharma representative, that, you know, when you're buying insulin at retail, there's a lot of different people's profits are in that amount that would be paid out for a vial of insulin at the pharmacy if you were paying full cost. So if we, in the bill, we are charging back to the, and I know Representative Howard will correct me if I'm stating this wrong, but we're charging back to the manufacturers the cost of the insulin, basically the retail cost that's being provided to patients. So at that point, if we're thinking about the actual cost to the manufacturers, baked into that retail price is a profit that the manufacturer is also taking on that vial of insulin, right? So what I'm wondering is, maybe this is a little too convoluted, but is there anything in the fiscal note that reflects that the manufacturer wouldn't actually be paying the full cost because they're actually also making some money out of that retail price? Mr. Berg.
Madam Chair, I'm going to answer the very specific question you had and maybe punt it over to Mr. Chun. I don't know yet. I'm not aware that there's anything in here that addresses kind of what you're trying to get at. But I think the issue that I know Mr. Chun and the author have talked about is the issue of, because we're using the pharmacy system, the pharmacists need to be made whole on the price they pay for it, which you're getting at what is the manufacturer's cost, but
Yeah.
we have to deal with the pharmacies. And I don't
Okay, so in other words, Mr. Berg, thank you for that attempt. So I guess the point is that if we charge back this whole amount to the manufacturers, they in fact are not actually paying, we are overestimating what they're really paying because they are in fact getting some kind of profit out of that on the back end, which we would have to subtract if we knew what that was. Representative Howard.
Madam Chair, you're describing that well. In terms of the cost for an insulin manufacturer to manufacture a vial of insulin, according to public studies, is about $7. And they've sold that vial of insulin for several $100s to a wholesale manufacturer. And this fee would essentially have the insulin manufacturers buy back the insulin that they've already profited from. So the actual cost to the insulin manufacturers' bottom lines is far less than this amount. I will call attention to just the fact when you look at the amounts here and the amount of insulin per month, it just highlights how unaffordable insulin can be for people. It costs a lot.
Yeah, thank you, Representative Howard. Okay, we have some questions here, and Representative Munson is first. And did you want to call back one of the testifiers?
No, Madam Chair, I can ask the bill's author.
Okay.
First of all, I do want to point out that your discussion that you just had on the profits of the insulin manufacturer through this program is what I had brought up last year, because we're paying the full cost of insulin. It gives the insulin manufacturer that is making the highest profit margin could actually pay for the entire cost of the program. It creates an incentive to increase the cost. And so you're benefiting the people that have the highest markup in insulin. There would be no incentive for an insulin company to lower the cost of insulin given this program. And that's because of how you've written the bill and administered the costs. It's frustrating to me. I'm a big data analysis guy, so I had Access database with your last bill, trying to run the numbers and look at behavior of patients, of doctors, of insurance companies, of employers that have employer-sponsored insurance to understand what's going to happen when this program is implemented. And I am deeply disturbed that you have this bill for the third time in committee now, and we just got the fiscal note at, a half hour after the committee started. This is a finance committee. Each of us are supposed to critique the financials of this bill and the impact it's going to have to the state of Minnesota and our patients, and to not give us the financials until after the committee starts doesn't allow us to do our job. The first time you brought the bill, the same thing happened. It came in committee. Last time you brought the bill in the interim, we didn't have a fiscal note. And I know that you said that the cost wouldn't go up, but it hasn't changed that much since then. The costs have tripled. So it's frustrating to me that we can't actually have time to prepare for looking through this deep 34-page fiscal note. And I apologize to the people that were testifying because I didn't pay attention to a single word they said, because I'm looking at this fiscal note trying to figure out what's changed in this bill and what questions I can come up with. The first question I'll ask you, Representative Howard, is we talk about all the patients that we're going to reach out to, and this is a life-saving drug, and it's very important for people to have access to. But why only diabetics? Why not cancer patients? I mean, there's 1 million procedures in drugs and transplants and anti-rejection drugs for transplant patients. We sat in the Mayo Clinic with doctors and heard testimony about cancer drugs that cost $800,000 a year. Why not all patients? Why only diabetics are we giving access to, and why everybody else has unaffordable prescription drugs and surgeries and procedures that they also can't afford?
Representative Howard.
Madam Chair, Representative Munson, we absolutely need to address the broader crisis really facing Minnesotans that can't afford their prescription drugs. But this bill responds to something that is happening across our state that everyone here, I would suspect, has some connection to a family member or friend that has diabetes. 500,000 Minnesotans have diabetes, and we've heard compelling, powerful stories from all across the state of people that are in extreme danger. So we've spent more than a year working on this, and we need to move forward with this solution. But that doesn't mean, in concert, we shouldn't work to solve the larger challenge facing Minnesotans that can't afford their prescription drugs.
Okay.
Representative Munson.
On page 10 of the fiscal note, something jumped out at me here. Third paragraph from the bottom, where it says, MNsure assumes 4% of applicants will appeal determinations of ineligibility to the program. Does that mean that 4% of the people are going to be denied access to this program? And if so, I know that they say it's $325 per appeal is what their cost is going to be, which happens to be pretty close to what emergency insulin would be at the low end. What happens to those people that apply for this program? Obviously, they're going to apply for it because they can't afford insulin. Yet 4% of the applicants, and we heard about the 16,000 people that are eligible, what happens to those 4%? Is that this program is set out to just, we all agree that we're not addressing the cost of insulin here. We're not actually fixing the problem. We're giving emergency access to people who can't afford it and need it. Yet 4% of the 16,000 people that apply are going to be denied.
Representative Howard.
Madam Chair, Representative Munson, that percentage refers to the long-term insulin program, which is the concept brought to us by the Republican Senate that we've worked to find a compromise. On the emergency side of the program, those that attest to their eligibility are able to receive an emergency supply. And we think that's important because if you're facing an emergency, we need to make sure we resolve that issue. We get people insulin in their hands. And for that reason, on the emergency side, you can only do an emergency fill one time in a calendar year. To access a long-term supply of insulin, there are a few more expectations of patients and to connect you to other resources, like if you're available for Minnesota Care or some other public board. So that's where that number comes from. So it would not disqualify folks from receiving their emergency supply of insulin.
Right. And Representative Munson, we understand that if you'd had more chance to read the fiscal note, you would probably understand that distinction. And, you know, I apologize that we didn't have this earlier. In fact, I was asked by the staff, should we give it out now during the testimony or wait? And I said, give it out now, because even knowing what you pointed out, that it's hard to listen at the same time, but I did want to give members some opportunity to at least see the fiscal note before we have the discussion. This bill will also go to Ways and Means. I know not everybody's on that, but, you know, it's just, anyway, I understand.
Madam Chair,
I'm not, I'm just understand your issue.
I'm working on amendments to this bill, and this is a really important, this is the only Health and Human Services Committee I'm on. I was on policy 2 years ago, but we can't talk about numbers because we rarely have fiscal notes. So I want to improve this bill, and so I'm waiting on the fiscal note, and I know we've had conversations about it, but I can't offer amendments. I'm not on Ways and Means. But this committee spends 42% of all the money in Minnesota that we spend in government, and this is important. We're trying to control runaway costs, and not allowing us to constructively work on this bill in this committee because we don't have the fiscal note is frustrating.
Well,
I mean, I would like to make a motion that we just table it for a week and we can come back with good amendments to this bill and actually improve it so that we can come up with
Representative
something
Munson, I would
bipartisan.
suggest to you that sitting here in committee and offering amendments is often not the best way to work on a bill, and that Representative Howard is available and would probably be happy to meet with you. I would, many of us, you know, we work on bills. The best work is often done offline. And so, you know, I think, I don't know, Representative Howard, I'll let you speak for yourself on that matter.
Madam Chair, Representative Munson, I do know where you sit on the House floor, and would be happy to have further conversations
And
offline.
it's next to you, if I'm not mistaken, right? Okay. All right, thank you. Thank you, Representative Munson. Representative Cantrell.
Thank you, Madam Chair, and thank you, Representative Howard, for putting together what is a bill that will save lives. I know how much work has gone into this, and I know that you have worked tirelessly to make sure that the product before us is one that is likely to pass in both bodies and will ensure that all Minnesotans are able to get the insulin that they need. Just had a couple of questions for you. Madam Chair, Representative Howard, how many people in Minnesota are living with diabetes about?
Representative Howard.
I believe it's over 500,000, and I'm blanking on the exact percentage with type 1, and I'm sure someone here could correct me on that or have that number.
Yeah.
Okay.
Representative Cantrell.
Well, thank you, Madam Chair. Representative Howard. And do you know off the top of your head how much the cost of insulin has increased for, let's say, Sanofi and Eli Lilly, how much their insulin has increased over the past maybe 5-10 years?
Representative Howard.
Madam Chair, Representative Cantrell, it's tripled in the last 10 years, but there was a comment made by a testifier about that, you know, insulin has changed a lot since 1923. Well, it hasn't changed a lot since 1993. And at that, you know, around that time, a vial of insulin cost about $30, and now, as you can see from this fiscal note, it costs upwards of $350, a 1,200% increase.
Representative Cantrell.
Thank you, Madam Chair, and thank you, Representative Howard. Some of the rationale that I'm sure you've heard and some of the rationale that I hear as to why the cost of insulin has increased so precipitously over the past 5-10 years is spending on research and development, right? I mean, that's a really common one that I hear from the manufacturers. Well, it just so happens that Sanofi announced late last year that they're not investing in diabetes research and development anymore. So their insulin feasibly should go down quite significantly in cost if that stands to reason. But kind of even further more than that, over the past, let's say 5 years, and it fluctuates a little bit from year to year, but over the past 5 years, Sanofi and Eli Lilly have taken turns spending more money on advertising than they have on research and development. So while patients are struggling to afford the cost of life-saving insulin, we have these manufacturers producing really nice TV ads or trying to market their products. Product, like you said, that has changed quite a bit, but nonetheless has existed and was given away for, what was it, about $1? The patent was sold for in the 20s. So I just wanted to really quickly kind of tie these things together. Really quick, the low or copay or no copay for insulin from the health insurance companies is not a permanent fix. I have a good feeling that as soon as the legislature no longer is paying close attention to this issue, that those copays will begin to go up again, which is why we need something like this, something I think kind of working more towards a permanent approach to preventing price gouging of our patients by all of these entities involved in the handling of health care. Because a voluntary policy from a health insurer is not something that is codified into law. What I'm also concerned about is as for-profit health plans are now able to sell health care in Minnesota, that we will see even more egregious price gouging on insulin, on all drugs and services. And I just want to say really quickly about the component of why aren't we doing this for cancer patients, for example? Representative Acom and I are the resident members of the Cancer Survivors Caucus at this table. And I want to tell you, I 100% would give up a week of chemo. I'd give up everything to make sure that a young person doesn't have to die from a lack of access to insulin. Because when it comes to chemotherapy, when it comes to radiation, you know, we want people to be able to get every bit of their treatment. We want people to be able to afford the outrageous cost of chemo and radiation. But, you know, we're not going to die typically in 24 hours if we have to wait a little bit for our chemo or we have to wait a little bit for our radiation. But for someone with diabetes, that is a life-threatening condition to encounter. Let's see, what else? Patients, the claim that these wonderful patient assistance programs exist and therefore our problem has been solved already by these companies is specious, to say the least. If they exist, if they're so good, how come people are dying? How come people continue to come to us and talk about how they're rationing insulin, how they're unable to get the basic supplies they need to survive? These programs are far from sufficient. And I find it to be rather shallow that there's a claim that they'll take care of the problem and that patients just need to do a little bit more research. Patients just need to know a little bit more about these programs and then they won't die. I think that is inappropriate.
Okay.
Oh, and really quick, I promise I'm almost finished, Madam Chair. Just one last thing that I wanted to touch on is it is the legislature's responsibility to be responsive to people, to make sure that people do not die from egregious abuses in our society. And that includes price gouging and abuse within the healthcare and pharmaceutical industry. So just really quickly, I want to say that taxpayers have funded a good chunk, especially speaking recently, of the most innovative research in healthcare through the National Institutes of Health. So we've already compensated these entities for the research they're doing, and I would be very skeptical of a challenge to that because the taxpayers have paid for this, and we deserve to not die from treatable illnesses like diabetes. Thank you, Representative Howard. Thank you, Madam Chair.
All right, thank you, Representative Cantrell. So members, just so this committee goes until 2:15. That's 20 more minutes. Let me just tell you who's on the list. Schultz, Grunhagen, Baker, Schumacher, Hamilton, and Jordan. So just so that you're all aware, and we may want to call up some testifiers if you want to actually ask questions of them. So Representative Schultz.
Thank you, Chair Liebling. I have a question on the fiscal note on page 16. So I'm looking at the table of the emergency insulin program, the cost of insulin. So it comes in at $36 million. If the manufacturers were to set their cost or price at $100, the fiscal note would be drastically reduced. Is that true, Doug? That if the price was set lower, we could see at $100 it'd be like 1.66 million rather than 36 million?
Madam Chair, Representative Schultz, I haven't done the math, but you're right that if the cost for the product were less, the total cost would be less, yeah.
Yeah,
Okay,
Representative
so
Schultz.
that's a very large change, that if the manufacturers would lower the price, the fiscal note for this bill would be drastically lower.
Yeah, and Representative Schultz, I would venture to guess that fewer people would need to use the program too. So there'd probably be an extra reduction there. Representative Gruenhagen.
Oh, thank you, Madam Chair. I'd like to call up Catherine Commit and Sharon Lamberton. They come forward.
Okay, Ms. Schmidt, Ms. Lamberton, please come back.
Yeah, and while they're coming forward, I just say that I've sold health insurance since 1978. I have customers and relatives who have diabetes, and I am as concerned as anybody about the cost of prescriptions, not only with insulin, but also cancer and other types of drugs. I had a client recently he was paying $9,000 a month for one pill to suppress a aggressive cancer. It didn't cure, just suppressed it. Fortunately, between a subsidy from the pharmaceutical company and his Part D drug plan, he wound up paying about $2,700 to $3,000 a year out of pocket. $9,000 a month, it's ridiculous. So anyway, my question to you is, this negotiations as far as the insulin program has been ongoing during the interim, from last session to this session. Were either of you or both of you a part of that discussion?
Who are you directing this to, Ms. Lamberton?
Both.
Well, okay, Ms. Lamberton, go ahead.
Madam Chair, members, yes, sir, we have been involved with discussions for the past couple months.
Representative, Ms. Commit, go ahead.
And Madam Chair, members of the committee, Catherine Commit from the Council of Health Plans. Yes, we have talked to the authors about this proposal as it was being contemplated.
Representative Gruenhagen.
Oh, thank you, Madam Chair. Yeah, so you gave some compelling testimony in terms of cost and the result of this particular bill and its weaknesses. Does the Senate bill address some of your concerns versus the House bill, or is there still some negotiation to go on? Because we certainly don't want to drive the cost up any higher, and yet we want people to have access to the insulin program.
Madam Chair,
Ms. Lamberton.
members of the committee, we still have concerns with the Senate version as well, but we have been in discussions with the members of the Senate as well.
Ms. Commit.
Madam Chair and members, we're fine with the Senate bill. We've been talking to Senator Jensen, who is now the chief author of that legislation, about a couple of clarifications to the notice provision, but we're fine with it.
Representative Gruenhagen.
Oh, thank you, Madam Chair.
And Representative Gruenhagen?
Yep, I know there's other people on the list.
No, that wasn't what I was going to say, but go ahead.
I thought I
All
read
right,
your mind,
thank you.
to tell you the truth.
Thank you, no, not so far.
Okay. You know, when we were down in Rochester, we talked about the high price of drugs, and we met with Dr. Vincent Rajakumar, if I pronounce that correctly. I had whole language, not phonics, so I'm as close as I can get. But anyway, and he basically stated 3 reasons why the price of drugs has gone up dramatically. And I think it's a travesty, not only in insulin, but right across the board. Number 1, Medicare can't negotiate discount prices. And of course, that's a federal issue. We can't do anything on the state. A ban on importation of cheaper cost drugs, and that's also Congress. And I would add, he didn't say this, but I would also add, pharmaceutical companies are charging a lower price overseas, and American consumers and patients are actually subsidizing that. And I know the Trump administration wants to put an end to that. And then his third reason that he mentioned was PBMs. You know, the amount of discounts that were available and that they're not getting down to the actual patient. So, based on the testimony, Representative Howard, it doesn't seem like your bill addresses that PBM issue, which was testified here, and in fact will actually cause the price of insulin to go up. Can you respond to that, please?
Representative Howard.
Madam Chair, Representative Gruenhagen, this bill doesn't in its entirety attempt to solve the prescription drug crisis and each of the actors. We do need each actor in the supply chain to step up and have a role in solving this. I am very supportive of the PBM reform bill passed by Representative Mann and an array of folks that worked on that on a bipartisan basis, including Representative Munson. But the list of those issues aren't addressed in its entirety in this bill. But overall, what we're trying to do here is say that insulin manufacturers, yes, you have a role in solving this crisis.
All right, last thing, Representative Gruenhagen.
Thank you, Madam Chair. Yeah, on the fiscal note on page 9, under assumptions, I just draw members' attention. It says roughly 70% of eligible Minnesotans, or 16,600 individuals, will participate in the emergency insulin program. And that's about 13,100 individuals. So we're leaving 3,000 out for some reason. And why, what, pardon? Oh, it's short-term, long-term. Okay, I had somebody whisper in my ear what the answer was for that, though. Okay, with that, I'll let some additional people have questions.
Okay, and you know what, Representative Gruenhagen, I think your question is well-founded, and I think I'm going to let Representative Howard address that.
Okay. Thank you, Madam Chair. The 70% figure is important for us to consider because that is the take-up assumption. So that's assuming that of our eligible population in this fiscal note, that 70% of those people will access the program and access the emergency program. I would submit that I think that number is severely inflated. When we passed the bill off the House floor in the session, there was a take-up assumption of 25%. This is almost 3 times that. And, that drives quite a bit of the cost because the more people that use the program and with the high cost of the insulin, I mean, that's really, that 1% has a big factor in the cost. And that is one reason why in this bill we've included language, it's a settle up really. So in the first year of the fund, we need to make a guesstimation. And, we have to make assumptions and guesses and try to determine how many people are going to use the program. But we've included settle up language, so at the end of that year, if we're assuming 75% and it's actually closer to 25, this fee will over-collect resources, and we want to give those resources back to the manufacturers. In subsequent years, we'll have actual data from the first year. We'll know how it's utilized and have a better way to calculate that. But that figure, there's a great degree of variability about how many people are going to utilize the program, and we've structured language so the fee will cover actual utilization essentially.
Okay, we have still Baker, Schumacher, Hamilton, Jordan, and then if we have time, Mann and Haley. But unless it's something, Representative Haley, was it just a clarification?
It was, Madam Chair, I guess, because my question was related to this discussion, and I was wondering if anybody from, was it the Department of Health or MNsure that we could talk to on how they got to these assumptions of 70% versus 25%?
Yeah.
Or is that something for a later day?
Yeah, that will, I'm not sure we'll have the time to, because I think, but they are here in the room, and you could certainly, we'll see how far we get here, okay? See if we can zip through, maybe we can come back to that. Representative Baker.
Thank you, Madam Chair, and thank you, Representative Howard, for carrying this bill. As you recall, a year ago, I was in your back pocket pushing hard. This is a big deal. Of anybody sitting here, join this effort of really wanting to hate on Big Pharma and what they've done, but this isn't the way to do it. I have to tell you, a lot has changed from a year ago. And as a guy that wants to write legislation with emotion, we can't do this. This is not good legislation, in my opinion. It's a bit bumpy, and the system is at failure here. When I heard the news this summer that the insulin manufacturers actually came to the table with some programs. And I heard that the no deductible, $25 deducts, and they got a little longer range plan. I'm like, Howard, you did it. You won. I couldn't get the opioid manufacturers to the table. I fought like crazy a couple years ago. I just begged them, give me something. I would stop this litigation, this legislation that is where we shouldn't be doing this. What we are trying to fix here is someone like Ms. Munson should never have to pay $1,300 for some insulin for her daughter. Never, ever. And we, as a state and a system and a government, we mess this all up from the federal level all the way down, from PBMs to manufacturers to medical systems, hospitals, everybody along the way, including us citizens, because we put people in those positions that made decisions because we thought government could fix health care. And look what we have today. So I want to make sure we as legislators that have an election certificate, I want to remind us that I sat there where you are fighting for what I thought was right. And I am so a supporter of what your passion is here. Alex Smith should never have died, but our system failed him. What we're trying to fix with this bill, I think, is sort of like a pimple on the elephant. If we do something here and we overreach and we spend $34 million on this thing, or we and manufacturers, it's going to come back and it's going to just get worse and worse and worse. We're not getting down to the core of the problem. So I like what we're trying to do, and because of the noise that was created here last year, because of your work, because of our committee's work, and because of how messed up our system is, we got them to the table, and you should feel good about that. If nothing else changes, they came to the table with a solution. Now, these ideas maybe aren't perfect, and I think I heard some comments from my colleagues. They could stop them at any time, and we should address that. That is a very legitimate point. But to have government come in and try to fix this, I think is maybe something we need to step back with. I know we've been talking about this for a couple of years. I feel like this is being rushed through again because it's headline news. It's because it's what people want to do, because people want to be angry at somebody because health care is broken. I just want to caution us to not emotionally legislate laws when we really got to dive into the problems of PBMs, of hospitals, of some providers, of manufacturers, the wholesalers. We have a system that's broken, and I am one of the first ones that want to stand up and help fix this. But I want to just say that we can make some of these things better. I want to actually say thank you to the companies for listening to you, to coming up with something. And it's not a bad program. Can we make it better? Yes, but you won here too. We won to some degree because there's something in place that you didn't have a year ago. And it's because of the work here. So I just want to be careful because this has a lot of moving parts. We have a broken system, and I hope that we can all together get down to the bottom of this stuff. And it's insulin today, but it's going to be something else tomorrow. So thank you for winning, and thanks for getting him to the table.
So, yeah, so Representative Baker, I just want to say first of all, and to all the members, this is not the only drug bill that we're going to hear this year. This is certainly not the only thing that's being put forward. This is in no way being put forward to address the entire problem of drug costs that are out of sight for cancer drugs, for anything, even for insulin. This is an emergency bill to stop people from dying. That's what this bill attempts to do. And the piece about the longer term was because the Senate came forward with that, and the bill is a bit of a compromise to try to incorporate their concern, that it not just be a one-off and then people are back on their own without any follow-through. So none of us, no one here, not Representative Howard, not anybody is saying that this is going to fix the problem. I just want to put that out there so we can move away from that. And Representative Howard.
Mr. Chair, I'll be brief because other folks have questions. And I just want to say first, I appreciate the praise, but any sort of praise of progress that's been made is due to the Minnesotans like Nicole, like Kim, and folks that have shared their personal stories. They are moving the needle. But what I don't want us to do is, because we've moved the needle in some ways, that shouldn't take away the feeling of urgency to do something about the emergency issue. Just since last session, 2 Minnesotans have died. And we have made some progress with these programs, but it is not a true safety net for Minnesotans. And we're moving quick on this session, but we have been working and meeting for months and months and months because we do need to get this right. It would be a mistake to set up a program. Patients with diabetes have a lot of experience with programs like this that don't work very well. We need to set up a program that will work, and we believe we've crafted something that isn't reinventing the wheel. Although it's a new program, we're utilizing infrastructure that allows us to not reinvent the wheel, and we're just simply asking that the manufacturers, it's common sense really, rather than emotion, just that insulin manufacturers share in the solution. But thank you.
All right, Representative Schumacher, then Hamilton, then Jordan. Representative Schumacher.
Thank you, Madam Chair, and Representative Howard. Just trying to breeze through the fiscal note here a little bit and trying to compare it to what we had last year, and I don't remember exactly what last year's was, if it was that significantly different than what is being presented here. And so I was just wondering, so obviously you're handling this very well on what the fiscal note is showing here, so you might have had a little bit of knowledge of what was coming forward. So if you could just compare the fiscal note from last year and what the bill was like last year versus this to describe what differences might be there, would be appreciated.
Yeah, thank you, Representative Schumacher. Representative Howard.
Madam Chair, Representative Schumacher, really good question. Last year, the bill had a fiscal note of about $11 million per year, and I would say the two biggest differences, one is on eligibility. We've now, based on feedback from patients, included folks on Medicare that are in the income range and have high out-of-pocket costs. We've learned that that is a significant population at risk for rationing. So there's a expanded universe of folks available. And then by far the largest cost difference is that take-up assumption. When you go from 25% to 70%, you're essentially tripling the cost of the insulin in the program. So those are the two big factors that are driving the cost difference. There are, because we're doing a longer-term program as well, there are more programmatic costs associated with that. But in order of magnitude, it's really those two previous items that I mentioned.
And thank you, Representative
Schumacher.
Howard and Madam Chair. Two other real quick questions. The counties, it's noted in here, may have some cost, it's assumed, based on an increase in applications for medical assistance, but it's not, the note on the top pages don't show any local fiscal impact. Do you have any kind of idea of where that might be landing?
Representative Howard.
Madam Chair, Representative Schumacher, I haven't reviewed that piece, but I'm guessing that's coming from the notion that when we get folks onto the long-term side, there may be some folks that realize they're available to participate in public health programs. Just given the volume of folks, I wouldn't anticipate that's a huge number of folks, but I haven't reviewed that exact piece in the fiscal note and can follow up.
Okay, thank you, Madam Chair and Representative Howard. And I'm assuming that the counties will be into chat if that gets to be a bit of an issue there for them with that, to reflect that in the fiscal note. But the final question we have here is just the cost sharing piece of that. Is that reflected in this note, in the fiscal note yet, on what that cost sharing will be for what we have here?
Representative Howard.
Madam Chair, Representative Schumacher, I haven't seen that piece of it, but I wouldn't assume that there would be a state cost associated with that provision.
Mr. Berg.
Madam Chair, again, I have to review this more thoroughly, but I don't believe there is, this reflects the cost of the program as the bill states it, without, if your question is it the cost sharing coming in to offset it, I don't believe that's in here.
Okay, thank you, Madam
I
Chair.
could be
Thank
proven
you.
wrong.
Representative Hamilton.
Thank you, Madam Chair. My dear friend, Representative Baker, talk about hate on Big Pharma. That's me. Talk about hate on PBMs. That's me as a legislator. And I've shared my story multiple times, and I'm angry. You know, not only what has happened to me personally, but I've listened to the testifiers. Ms. Munson, thank you for sharing your story, for coming down here, because I know it's not easy. But it's maddening as a legislator to hear that. Ms. Turner, I heard what you said. Not only did I hear what you said, I saw the tears welling up in your eyes and the crackle in your voice about what you have experienced personally. Thank you for sharing that. And of course, Nicole Smith-Holt, I've heard your testimony multiple times. I've seen the tears. I've cried along with you. And it's frustrating. It's mad. It just makes you so angry. And Representative Baker, you and I have had these conversations. You are my friend. And I said, as a legislator, I despise the business practices that are taking place. Whether we're talking about drug companies, insurance companies, pharmacy benefits managers, I despise them. As a patient, I fear them. Think about that. So, you're absolutely right. If I could get a pound of flesh, I would take 100. That's how angry I'm at. I've served on this committee for many years, over a decade. And I've heard the stories on how real people are being harmed. I thank you for having that thoughtful approach, because you're absolutely right. We need level heads. And I hope that you will maintain that as well, Representative Howard, because there's a reason why I'm not carrying these, because I'm so upset that I don't want that to be guiding the decisions. But I do think if you have your foot on their throat, keep stomping, because they did not come to the table out of the kindness of their heart. They came to the table because we had the public outcry. We had legislators that were willing to stand up and say enough, and that's what we need to do. Now, Representative Howard, I'm going to support your bill today. I do have a few concerns. And I ask that you do work with the Senate on this, because we do need to have something in place. And I can get up with you later on what those concerns are, because I know we're out of time. But again, emotion is involved because real people have been harmed. Thank you, Madam Chair.
Thank you very much, Representative Hamilton. And you know what? We, on this committee, really appreciate your voice on these things, and we're right there with you. And yeah, the tears were there. I was crying along with Mary Turner, indeed. Representative Jordan.
I can pass.
Okay, she's going to pass. Representative Mann.
Thank you, Madam Chair. So I just, a couple comments. One is I agree with Representative Baker that our system is messed up. I don't agree that it's broken. I think it's actually functioning exactly the way that it was designed to function. We have a for-profit system, and that's what every entity is doing. They're making their profit. So I agree that we have to change the entire system. However, this is not what this is, right? This is an emergency insulin bill for people in crisis. So just to give you an example, very, very quickly, but just to give you an idea of what urgency and emergency means, is that I saw a patient in the ER at 10 a.m. one morning. 10 a.m., diabetic, type 1, in DKA. She said, I don't know what happened. I feel horrible. My monitor says my sugars are too high. I can't get them down. I don't know what's happening. I said, when did you change your pump? And she said, 9 p.m. last night. So I took her pump off, and her needle was kinked. 13 hours she was in the ICU that day. That is the emergencies we're talking about today. 13 hours. So you can be, we can solve this one issue. Let's prevent people from dying and vote for this bill. And then let's tackle the issue that led to this bill in the first place. And Madam Chair, I would also like a roll call.
All right, roll call having been requested. So members, we are 5 minutes over. We could be in the room for another 5 minutes, but we are going to vote on this bill before we leave the room. So I had two members down. I know Representative Haley, I just don't think we have time to deal with yours. I know Representative Francis on here. I think we, unless it's really short, Representative Francis, go ahead.
Thank you, Madam Chair. And Representative Howard, just question here. Has there been any talk about litigation if this bill is passed, signed into law, if there is litigation, how does this work for making sure people don't fall through the cracks?
So, little quick question, Representative Howard. Go ahead.
Madam
30
Chair,
seconds.
Representative Franson, we've heard just in the last week, basically, for the first time about this kind of allusion to a constitutional issue, and we are looking into it. I will say, and Representative Baker can probably relate to this, it's nothing new to hear threats of lawsuits from the drug companies, and what we need to stay focused on is what's best for patients and for Minnesotans, and so, but we are looking at it.
All right, thank you. Okay, we got to get out of here, Representative Franson.
All right, then, thank you, Madam Chair. Then perhaps going forward, we should be a little bit more realistic that if, once this bill passes, it's possible that there still will not be any assistance, and to be just a little bit, if it's tied up in litigation, we don't want people thinking that there's going to be help tomorrow when it may be tied up in the courts for some time.
Right. We don't want them thinking that they can live another day,
Yep.
I guess, Representative Howard, right?
Madam Chair, I'll just say briefly, I would like us to consider, folks can think what they want about the drug manufacturers, but in that scenario that we've passed an emergency insulin bill, and to think that these 3 drug manufacturers are literally going to take the insulin out of the hands of somebody that needs it to live, I certainly would hope they wouldn't do that.
Right. Thank you, Representative Howard. The clerk will take the roll. Oh, and so the chair renews her motion that House File 3100 as amended be recommended to be re-referred to the Committee on Ways and Means.
Liebling.
Aye.
Schumacher.
No.
Acom.
Yes.
Baker. Bierman.
Yes.
Cantrell.
Yes.
Franson. Grunhagen.
No.
Haley. Halverson. Hamilton.
Yes.
Jordan.
Yes.
Keel.
No.
Kunish Padine.
Yes.
Mann. Moran. Noor.
Yes.
Oops, sorry. I missed Munson.
Nay.
Munson, no. Noor.
Yes.
Olson.
Yes.
Schultz.
Yes.
There being 11 ayes and 7 nays, the bill is passed and on its way to Ways and Means. Now, members, I forgot at the beginning to just get a motion to approve the minutes.
So moved, Madam Chair.
All right, Representative Cantrell moves approval of the minutes of February 13th. All those in favor, please say aye.
Aye.
Opposed, no. Motion prevails, and thank you, members. We are adjourned.